Dr. SN Medical College in Jodhpur. After that, I spent some time in New Delhi, then England, and then I came to USA. I'm extremely humbled that Namaskar and good evening. I am Ramakant Sharma. I am Namaskar and good evening. I am Ramakant Sharma. I am one of the critical care medicine physician at Honor Health Shea Hospital in Scottsdale, Arizona, USA. I graduated in year 1992 from Dr. SN Medical College in Jodhpur. After that, I spent some time in New Delhi, then England, and then I came to USA. I'm extremely humbled that I've been given the opportunity to talk about non-invasive ventilation in COVID-19. I'm especially thankful to Dr. J. Rathod from Florida, who created our organization called DORI, Mr. Dheeraj Srivastava for coordinating the efforts of Government of Rajasthan with our organization, Dr. Sudhir Bhandari for selection of the topics and organization. I do not have any conflict of interest for this talk. I do not have any financial interest. The level of this talk, it at the level of first year resident in medicine. As we are all aware, we are going through the pandemic of COVID-19 caused by novel coronavirus called SARS-CoV-2, which was first detected in December 2019 in Wuhan, China. It is a highly contagious virus, and healthcare workers who take care of airway management of the patient are at risk of getting this virus. About 20% of the patient will develop hypoxia, out of which 10 to 20% will require ICU admission, and 3 to 10% will require mechanical ventilation. People who require ICU but not the invasive mechanical ventilation will benefit from non-invasive ventilation, and this topic is about that. When the pandemic first struck in Wuhan, China, non-invasive ventilation was not used frequently. Most of the patients were intubated to treat the hypoxia. The reasoning behind that was the healthcare workers needs to be protected from the infection. Non-invasive ventilation was thought to generate aerosol and cause high rate of healthcare worker infection. Furthermore, once they intubated these patients, they were not able to wean them successfully. For these reasons, when the pandemic struck in Italy, non-invasive ventilation was used more frequently and with good success. SARS-CoV-2 is no different than any other common respiratory pathogen which causes ARDS. Initially, there were thought to be two types of phenotype, L and H, but eventually it leads to the diffuse alveolar damage in patients with COVID-19, and the principle of management remains same whether it's SARS-CoV-19 or any other respiratory pathogen. The only difference is we have to be very careful about the infection control policies and procedures in this pandemic to prevent infection to the healthcare workers. Although non-invasive ventilation has been used in COVID-19 now more frequently, there are no randomized trials to show their efficacy or their problems. The primary problem in COVID-19 is respiratory and that is mainly hypoxic respiratory failure. Although some patients may develop what we call multi-organ failure due to cytokine storm, but that proportion is not common. The primary mortality in COVID-19 is still related to ARDS, diffuse alveolar damage, and respiratory failure. Supplemental oxygen is mainstay of therapy, the supportive therapy, which can be provided with nasal cannula, which can deliver up to 6 liters. Then we can go to Venturi mask, which can provide oxygen up to 50%. A combination of nasal cannula and non-rebreather can provide much more oxygen. But none of these initial oxygen therapy can provide some sort of pressure support. There comes the role of non-invasive ventilation. High flow nasal cannula, BiPAP, and CPAP are the three modalities of non-invasive ventilation which can provide a little bit of pressure support too. And we will discuss these today. The first non-invasive mechanical ventilation modality is CPAP, also known as continuous positive airway pressure. This device delivers a constant flow of oxygen at a prescribed pressure, which is measured in centimeters of water. This pressure keeps the alveoli open, increasing the lung volume, and it reduces the distance between the alveoli and the blood vessel, which improves the gas exchange. It helps mainly with hypoxia, not much with the CO2 retention. To be effective, there need to be a very good seal around the nose and face to maintain this pressure. Bilevel positive airway pressure or BiPAP is an improvement on the CPAP. In addition to having the PEEP, which is also called as EPAP or expiratory positive airway pressure, they have an additional inspiratory positive airway pressure, which can range up to 35 centimeters of water. The difference between the two is called pressure support, and at least 8 centimeters of water should be there to begin with. If there is an issue with CO2 removal, the goal of therapy is to increase the difference between these two pressures, thereby increasing the tidal volume and improving the CO2 removal. Another advancement on BiPAP is called AVAPS. It is average volume assured pressure support. In BiPAP, the physician or the respiratory therapist has to adjust the EPAP and IPAP to generate the desired tidal volume. In AVAPS, the average tidal volume is assured by the machine, and the way they attain those tidal volumes is by adjusting the inspiratory pressure or IPAP automatically based on the tidal volume generated. The pressure support will change at the rate of 2 centimeters per minute if there is an unstable breathing, or 1 centimeter per minute if there is stable breathing. The PEEP or EPAP can be adjusted in this modality based on the degree of hypoxia. Traditionally, high-flow nasal cannula is not considered a non-invasive ventilation, but it does provide some degree of pressure support up to 5 centimeters. Therefore, it is now included in the non-invasive ventilation settings. A traditional nasal cannula can only effectively provide oxygen up to 4 to 6 liters per minute. In high-flow nasal cannula, there are two separate systems. One is a flow generator which provides the gas flow up to 60 liters per minute. The other one is called oxygen air blender, which adjusted the FiO2 from 21%, which is room air, to 100%. High flow nasal cannula can provide up to 100% of humidified and heated oxygen and at the rate of 60 liters per minute of airflow. It is thought to cause reduced physiological dead space, and it provides up to 5 cm of positive and expiratory pressure. COVID-19 patients who develop hypoxia are provided supplemental oxygen, initially in form of nasal cannula. The hypoxia is defined as PO2 of less than 55 mm of mercury on ABG or saturation less than 92%. For the treatment purpose, with steroids though, the saturation are less than 94%. Once you provide oxygen to these patients, and if they are maintaining the saturation above 92% and their respiratory rate is less than 30, you continue this. If there's a deterioration in oxygen saturation, initially we can try high flow nasal cannula. That is determined by if the sats are less than 92% in the otherwise healthy person or less than 88% in the patient who has COPD, or if their respiratory rate is more than 30. You provide them with high flow nasal cannula. The rate and FiO2 is adjusted based on saturations as well as comfort of the patient, and we reevaluate them in 1 to 2 hours. If this improves their oxygenation and comfort, you continue with the high flow nasal cannula and attempt to wean the FiO2 as well as flow based on their recovery. Usually it's done in increments of 5 liters per minute. If the high flow nasal cannula does not provide you enough oxygenation or patient's respiratory rate is not there satisfactorily improving, we can try CPAP, which usually starts at 10, but it can be anywhere from 5 to 10, goes up to 18. And again, the patient is evaluated in form of respiratory rate, their comfort, oxygenation, and their CO2 level. The goal also is to keep the tidal volume less than 9 mm per kilogram body weight, ideal body weight. If there is a evidence of retention of CO2, we switch them to BiPAP mode, and the PEEP pressure or EPAP is adjusted for the hypoxia. The pressure support is adjusted for the CO2 removal. Sometimes you have to give hit and trial of various settings which best suits the individual patient, because each patient behaves differently in such circumstances. The patients on the non-invasive ventilation, especially the COVID-19 patient, can be there for prolonged period of time, and in our hospital we have seen patients staying on those modality for 1 to 3 weeks, and I will talk in next slide the issues with this prolonged support. Furthermore, once you put them on non-invasive ventilation, you also have to evaluate them if they're improving, they're stable, or they're deteriorating. If there is a deterioration, you check them in 1 to 2 hours in the beginning, and if they do not improve, you need to consider intubation. Intubation should not be just considered based on the X-ray or degree of hypoxia or CO2 level. Overall, it's your clinical judgment. We have seen patients who have been hypoxic in 80s, but they appear comfortable, and we keep them on non-invasive ventilation for weeks. Whereas some patients are not even hypoxic, but they are in severe distress, and you have to intubate them immediately. CPAP fails. So Overall, it's a judgment call by the treating physician rather than individual number. There are certain contraindications to non-invasive ventilations, especially patients who are not cooperative, those who have a Glasgow Coma scale of 9 or less, those who have facial injury, burns, anatomical disorders which makes the mask fitting very difficult, or those who are producing a lot of secretion and they are at risk of having an aspiration on top of their existing COVID disease. Also, patients in shock or severe metabolic derangement can't be put on non-invasive ventilation. Non-invasive ventilation is not without its complications. Most common is facial skin necrosis, especially on the bridge of the nose. We do have some gel pads specifically made for the prolonged use of the mask in these patients. You can develop conjunctivitis, nasal irritation. Generally, it's not comfortable for a lot of patients to wear the mask continuously. The positive pressure can lead to aerophagia, which is distension of the stomach with the air. And there's a problem with the mask fitting as well. So if there's a significant leakage, the purpose of the non-invasive ventilation is defeated. So in these circumstances, the physician has to make a judgment call whether to continue with this modality of treatment or go with the mechanical ventilation. Patients on non-invasive ventilation are also at risk of self-induced lung injury. This picture shows the mechanism of that. In COVID-19 or any ARDS, there is capillary leakage, pulmonary edema leading to impaired gases exchange and change of respiratory mechanics, which leads to increased respiratory drive, which leads to a wide pleural pressure swings, and that is the mechanism of self-inflicted lung injury. There are several benefits of non-invasive mechanical ventilation. First and foremost is to not use the invasive mechanical ventilation, thereby preventing the harmful effect of the mechanical ventilation, which includes related to pressure or barotrauma and the infectious complications of the intubation. Also, in this pandemic, there are limited resources. So if we can avoid intubation, it is better for the patient and the community because there are limited supply of ventilators in various settings. Also, patient is not subjected to various sedatives, thereby protecting their natural reflexes in the upper respiratory tract. Patient can cough and he is able to talk and express his wishes in case he does not want certain treatments. They are generally more comfortable than the tube in the throat, which is intubation. And obviously we avoid all kind of sedatives and muscle relaxants and opiates in the patients with the non-invasive ventilation. Furthermore, it's easy to take away the non-invasive ventilation from the patient, whereas if somebody is on a mechanical ventilation, it's hard to just take it off. Although non-invasive ventilation has been frequently used in COVID-19 pandemic, there is limited data about its outcome. I have found two references which shows it reduces the need for mechanical ventilation when used in appropriate patients, and also in one study it shows it reduces the mortality but the quality of evidence was very low. However, none of the references show that it is worse than not using them. So till we have a randomized trial, it is prudent to continue to use non-invasive mechanical ventilation in COVID-19. As you recall from the beginning of this talk, in Wuhan, non-invasive ventilation was not used frequently. All of the patients who required higher level of oxygen therapy were intubated for the fear of infection risk to healthcare workers. But since then, things have evolved and it is frequently used. I found two studies which looked, one in my alma mater. I did fellowship from Bay State in Springfield, Massachusetts. They looked at 1,635 employees and found that non-invasive ventilation did not lead to any high risk of COVID-19 in healthcare workers. Another one was a feasibility study of 297 patients which showed no increased risk of infection in healthcare workers when they use non-invasive ventilation. Infection control policies varies in United States depending on the part of country you are in, and the guidelines from CDC are mainly geared towards the patients and hospitals in USA. If somebody is not in USA, they need to adjust their guidelines based on what facility they have in their community. In this picture, what you are seeing is a temporary conversion of a patient room into negative pressure room. In our hospital, in the beginning, there were only limited negative pressure rooms, but we were able to convert all of our ICU in a negative pressure rooms using this type of equipment. We sometimes also put HEPA filters on this exhaust fan so that the virus does not spread in the air when it is pushed out of the room into the surrounding area of the hospital. But I understand that not every patient gets individual room in various parts of the world, so you have to adjust your infection control practices based on what is available locally. As we discussed earlier, patients of COVID-19 on non-invasive mechanical ventilation are in for a long haul and they need feeding. If the patient can take a break from CPAP or BiPAP, they can very well eat small quantity of food. Patients on high flow nasal cannula can easily eat, but there are several patients who are CPAP or BiPAP dependent. They can't take off their mask for a long period of time. In those, enteral feeding via the NG tube can be initiated. In certain hospitals, we have this special masks which you're seeing in this picture, where there are two ports. One is for NG tube and one is for the BiPAP connector to prevent leaks and easy feeding. There are certain patients who can't tolerate NG tube feeding and say develop small bowel obstruction or ileus or have constant nausea, vomiting. They need to be started on TPN. We have used TPN frequently in patients of COVID-19 who were BiPAP dependent and been there for a long time. Patients on non-invasive mechanical ventilation frequently required sedation which are not respiratory suppressant. We frequently use two drugs. Dexmedetomidine is a centrally acting alpha-2 receptor agonist, which is available in intravenous infusion, commercially known as Precedex. This drug does not cause any respiratory depression, and it will provide relief of anxiety from shortness of breath, but comes with the side effect of hypotension and bradycardia. This drug is most commonly used in the United States for patients who are slightly anxious and can't tolerate BiPAP or CPAP suffering from COVID-19. Another very good drug available to us is ketamine, which is a non-competitive NMDA receptor antagonist which blocks glutamate and causes dissociation by directly acting on cortex and limbic system. It is highly lipophilic and has a rapid onset of action. We tend to use it in an infusion form starting at 0.2 mg per kilogram per hour and can go up to 2.5 mg per kilogram per hour. We cannot use it outside of ICU due to regulatory structure, so it can only be used in ICU. It has very favorable characteristics in form of bronchodilation, preserving the cardiac output, and it increases the blood pressure. It does not affect the respiratory drive or bowel motility. Patients who are on chronic opioid and chronic benzos at home will continue those depending on their need if they are on BiPAP and have COVID-19. We all know that proning the patient of ARDS who are on mechanical ventilation improves mortality. The same principles are applied to the patients of COVID-19 who are on non-invasive mechanical ventilation in form of awake proning. It improves the oxygenation and respiratory status and decreases the need for intubation in early ARDS by a prospective cohort study shown in this slide. One important thing to remember is if the patient is prone when they are intubated, we only have lateral as well as prone position. In the patients who are awake, they need to adjust their position based on the maximum benefit noted, because not all the time we get the benefit only in prone position. Sometimes we get it in a left lateral or right lateral position. Most of our patients do self-prone, and we have not seen any adverse outcome due to awake proning in our patients. Unfortunately, there are no randomized trials, so we don't know whether it really works, but we do see improvement in oxygenation. This is a standard BiPAP machine we use in our hospitals, made by Philips. In the back, you have connection for via oxygen cylinder or oxygen tubing, which goes to the oxygen connector supplied throughout the hospital. These are the various tubings and connectors you need to connect the BiPAP machine to the patient. This is the heating chamber. It certainly fits in the space shown here. This is the bacterial filter, goes up, again the main outlet. The short tubing connects the bacterial filter to the heating chamber. This is the main tubing which will connect from heating chamber to the patient mask. This one has a heating sensor. And also has a tubing which measures the expired volume. Finally, it connects to the mask, which comes in various sizes and shapes. Uh, can be a nasal mask or a face mask or full face mask. Finally, the heating connection, and this is what you look in a screen when the BiPAP is turned on in the beginning. Various settings are available on this dashboard. This is a high flow nasal cannula machine which has a heating humidifier chamber and oxygen tubing along with two connectors or controls for the control of the flow and the FiO2. Finally, in the back, the similar tubing goes to the oxygen connector. Thank you very much for your valuable time. In case you have any questions, please contact me via email at ramakant41@gmail.com. Alternatively, you can contact me by phone 480-799-7007. Thank you again. Have a nice day. Please contact me over the email or the phone, and I'll be happy to answer any questions you have. Thank you very much for your appreciation.